Where's our narrator? Are we ready?
Ready. Lights. Camera. Case 3. 16-year-old female cross-country runner referred to your clinic with a diagnosis of left shin pain from her PCP. She started preparing for an upcoming race by running hardcore! Exclamation point, exclamation point. This patient runs about 30 miles per week and began experiencing left shin pain about 3 months ago. Despite the pain, she continued to train in the past 4 weeks, the pain has significantly worsened. The patient reports that she experiences 4 out of 10 left shin pain while running and 0 out of 10 pain performing activities, ADLs. Her goal is to return to the running pain-free.
What?
Her goal is to return to the running pain-free.
Thank you. It only takes me hours to write these short little vignettes. Little vignettes. All right, background info. Based on this patient's interview, you suspect what?
Tibial stress fracture.
Come to the front, please. You deserve to be on camera like everybody else.
I don't.
Yes, you do. Well, if that's nothing else, it helps your friend's study. Good. Tibial stress fracture. What populations are susceptible to this diagnosis?
The elderly, people with bone pathologies, and women, the triad.
Terrible triad.
What is the female unhappy triad? Say it to the camera, please.
Low bone mass,
Low bone mass,
low energy or energy deficiency,
right? Low caloric intake,
and menstrual
Disturbance.
disturbances. All three is called the triad. They all work together. You're not eating enough calories, right? Because you're training too hard. That means your bone cannot properly heal, right? Because you're not taking enough calories. And your menstruation is off, which is not only common with people that are energy deficient, but also female athletes. That
Which
all
are
leads to
patient
bone
is.
deficiency. Excuse me?
Which our patient is.
Which
is
are your
a young
patient?
female athlete.
Young female athletes. So that is the unhappy triad. Okay. What are some intrinsic causes of this diagnosis?
Like length discrepancy,
Okay.
high arch of the foot, tight or weak hip muscles, and hormonal imbalance.
And
Low lean muscle mass.
lean muscle mass, low bone density, all the things you said. We're going to learn how to test the patient's arch, if it's high or low. I know you can't wait. Yes. All right. What are some extrinsic causes outside of the area?
Poor training, poor footwear, and poor running form. Oh,
All right, very good. All right, the gold standard is what?
MRI.
Why MRI, not X-ray? Isn't X-ray the gold standard for bone?
It might not show up on X-ray in the first 3 to 4 weeks.
That's right. From 3 to 4, 3 to 5 weeks, hairline fracture might not even show up. So they might say, "Oh, go home, you're good," when they're not good. So MRI is the gold standard. Okay, let's quickly go over the phases of this diagnosis, shall we? First, we have what?
initiation.
Crack initiation.
Crack initiation.
Why does your group refuse to say the word crack?
Crack is what?
Initiation sounds like we're in a frat.
That's back in what's this?
What, initiation?
Crack thing.
I don't know. We're running out of space on the channel. All right, crack initiation. Ronald Reagan, just say no. His wife said. All right, crack initiation.
So the specific spot where the overload occurs.
Occurs. Very good. And crack propagation.
That's when the overload continues, so the body cannot repair fast enough.
It's normal for bone to be overloaded and break down, but healthy people build it up without issue. This woman has issues, right? Because of the unhappy triad. Finally, complete fracture.
It's at first it's only pain with activity, and in our patient case, right?
Yeah.
And as the stress progresses, there's a constant pain at the site of the injury, and the site is also tender to touch.
Tentative palpation. Very good. Okay, so you're pretty confident this woman has a stress fracture.
yes.
And you're congratulated for it. Now it's time to do some testing. First, we're going to do leg discrepancy, which you guys mentioned happens to be one of the reasons why a person can get it.
Yes. We had
Yeah.
a very good patient because he had a little bit of
All right.
discrepancy.
So, what are the spots that we're doing it on?
So we measure from the ASIS
Yes.
to the medial malleolus.
Very good. Show us.
So
Okay, ideally the patient is worth wearing just shorts or just underwear, because when you're wearing pants, you see all the
Yeah.
bumps and the crevices and the, yes. That's how you do it, very good. Now, what's the now I was
And
gonna
you
say?
compare it to the other
You
side.
have to compare it to both sides, obviously. And now, if you have a person that's not as thin and fit as Russ here, then what you do is I like to take the fat and turn, and then you push
Oh,
down that
yeah.
further right. But I'm not using me because I'm not fit. I clearly am. But
course.
if you're a person with a little more adipose tissue, you turn and push down, and that's exactly where the ASI is. It's easy on thin people. It's difficult on people with more adipose tissue. So I like to push and turn. Okay, very good. That's how you do it. Now, manual muscle testing. Again, you're going to be responsible for manual muscle testing. And we're not going to do it now
It's all
because
good.
you already learned it.
I can do it.
What is weak on this patient?
So glute max.
Glute max
Glute meat.
and glute med. Very good. The active strength testing, we already showed with the other group. This person might have a miserable malalignment, so we're expecting you to stand the patient up in one, thank you, and with one foot and look for the internal rotation and a deduction. If this person's an athlete, you might have them do, what do you call it again?
Or
Pistol squats or jumping, but I wouldn't jump with a person that has a potential tibial fracture, right? So that's what you're going to do for the patient. You're going to look for the basically internal rotation and a deduction. Okay, the other group showed an excellent way to test core, like you learned in kinesiology. We're going to show you one that Carlos and I use a lot. It's just cool. And this is called the what?
The unilateral hip bridge endurance test.
The unilateral hip bridge endurance test, which is perfectly self-explanatory. So the patient lies in supine, and they do a one-legged bridge, and they cross their arms over their chest. And you look, oh, you have the thing? You look for excessive swaying medial to lateral, or excessive dropping of the hips, which shows a sign of weakness. We do it for how many seconds?
23.
23 seconds.
I do gotta say, I worked out yesterday.
Go up.
Sure.
Oh my god.
Oh, we can get a level
Nice.
too, right? Like a plumber level?
It's like a level.
Yeah.
Yeah.
How you feeling, dude?
With a little bump.
Trust.
Carlos then will have you go on your tippy toe.
Oh god, no.
Stay there, stay there.
Wait,
No matter what side you do
Yeah,
it,
No, it doesn't matter which side. It doesn't.
so you can do it on your
You
dominant
could.
side.
They don't even ask for dominant. No, doesn't matter. Yes, good question.
Oh, that's wild.
There's another test that we used to use, the double leg
Yeah,
lowering
we do
test,
that.
but that involves like a blood pressure cuff. It's very difficult. It's very difficult. I love that. All right. Anyway. All right. Now. Now
They're
for
obsessed with you.
now for the special test. So, oh, we're gonna do it. This is. I don't
What?
like this test because I think that the inter-rate of reliability is really. The intra-rate of reliability is. So he's gonna pump it up to 40 millimeters of mercury.
Blood pressure.
He puts it by the L4 and L5, right?
You're gonna find I have severe low back pain, and I've been hiding it all this time. Now what? Do I do the test?
Well, you see he's moving already because it just dropped, right?
Yeah.
And both arms are across the chest.
Is he just supposed to
He
just
raises
sit
then
there?
raises both legs up in the air.
Yeah.
Straight leg raise both legs.
No.
Both
Ah.
legs. Good. Now he
Went up
sets it
to
to 40.
80.
Now set it to 40. Set it to 40 now. And now you're gonna lower your legs to the floor
He's shaking.
slowly, trying to maintain 40 degrees.
Lower
So-
them.
Lower the
Low-
elbows.
Now
lower your-
lower it slowly. The minute it goes
Oh, jeez.
10 degrees either way, we stop and we take a goniometric measurement, and that shows signs of weakness.
That right there, right?
Is this core weakness?
Huh?
It's already at 50, no?
I think. Oh,
Whoa,
he went
there
back
he-
up.
But I don't like this test because it's so hard to administer.
Yeah.
It's so I never get it right. Not only that, you could have like Superman or Superwoman. I don't even say Supergirl.
Person.
Super person.
Thank you.
No, to be fair, right? And if you bear down too much, it's not. It's.
Yeah.
I don't like this test. The research likes it. I don't like it. It's so hard for me to administer. Anyway, the special tests. Carlos, do you like using this test?
No.
Then you got to stop them and like goniometrically measure them.
No.
You need like 6 people to do this test, right?
2 involved.
2 involved. So we got rid of it.
NFL uses it.
NFL uses it. Soccer, FIFA uses it. But anyway, let's talk about the special test. So the patient, what are we doing first?
The hip tap.
Patient is supine. You're gonna lift the leg off the table a little bit, not too much. You're then gonna take the heel and get some aggression out. Boom, 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 boom. And a positive sign is where?
Pain.
Pain right, no, at the area where they came in.
Yeah.
It hurts in the
Yeah,
tibia?
Yes.
That's a sign there could be a fracture. Okay, next special test.
Short sitting. This is the squeeze test.
Yes, the patient is short sitting. You're gonna go,
Distal.
yes,
to where
distal to
say
the
it's-
pain.
Say it's here, so we'll go down here.
And you're squeezing the tib and the fib together, correct? You're squeezing the tib and the fib together, and a
Yes.
positive sign is
Ouch.
at the area,
Yes.
right? Very good.
Ouch.
Finally, the last special test,
Single leg.
single leg
hops.
hop test. So you ask the patient to do a number of single leg hops. If they really have a stress fracture, they will not be able to do
Yeah.
one.
That-
And
so
many
could be
times I don't
apprehension.
even do this test.
Yeah.
Because the patient tells me the
So they
story,
just don't
I
know
do
that-
this, I'm like, we're not even doing it.
Yeah.
Actually, if I get a positive diagnosis from the MRI of a tibial stress fracture, I don't do any testing. Why? Just for fun?
The proof's in the pudding.
No, that's how you get your jollies, that's how I get my jollies.
But what about the measurement?
Oh yeah, I'll definitely do the leg measurement for sure. Okay, okay, share with you colleagues some red flags regarding stress fracture. What are some things you learned from the red flag book?
The big one is if you get the fracture with no known
Origin?
Trauma.
Yeah.
alcohol use, poor diet, cigarette smoking, age, and then the corticosteroid usage.
Yes, so it's important to know what drugs they use. Are they smokers? Do they drink? Right? If they're a 15-year-old female who's an athlete, that's one thing. Very good. All right, now let's do some strengthening, shall we? Phase 1. It's a non-weight bearing. When I say non-weight bearing, I mean on the table. So there could be some weight going through the leg, but it's on the table in general. Okay? The reason why we're doing this is because some doctors, depending on how bad the stress fracture, will say non-weight bearing. Only can do exercises on the table. Some will say we're good, they could do light weight bearing exercises, but no jumping or running. So let's assume this person is starting with non-weight bearing and we're on the table. We're doing what? Isometric for glute med, isometric with core.
And then I'll let
So we're working,
Oh, yeah.
so if we're working the bottom leg, if the patient can tolerate it, that's good. All they have to do is hold that. If they cannot tolerate weight through that leg, they can do the top leg,
and
up
hold it.
and hold it isometrically. Got it? But most patients can handle the weight through the bottom leg. It's not stress through the tibia typically. Okay? Make sense?
Yep.
So that works. If you don't think that works the core, try it. If you don't think it works the glute medius, try it. It definitely does.
Yeah, I agree.
Next one. And if that's too difficult, do it not on the hand. How'd you do
Yeah, I
it?
did it
On the
here. You
elbow.
could
Oh,
also,
perfect. Yeah, that's
you
good.
could also do it like this.
That's good. All right, good. Next,
Nice.
this is glute med, non-weight bearing internal rotation.
Reverse clamp.
Reverse clamshells.
Reverse clamshell. So look,
So we
go
had
up, there's the
clamshells
glute
before.
med. That's not, yes, that's the
No,
reverse
no, no.
clamshell. So you see, she's up in the air, that's the glute med, and the reverse clam is the internal rotation.
Oh, so the
And
band would be at the
this.
ankle? The band would be at the ankle?
Band, yeah, you can put a band, or no band, depending on the patient.
Word.
I can't do 2 of these.
Yeah, I was like, as soon as you did, I was like,
Alright,
oh.
very good.
I don't
Now,
know, Chief.
this is the hardest one. Are you guys ready for this? Hip, non-weight bearing hip abduction.
That's the sideline and you lift the leg. That's the
lift your leg
one.
That's, yeah,
That's
that's
a
the
joke.
one
This is the
we,
easiest one you've seen a million times.
that's the one we did.
No, you don't have to go. No, it's
No
stand up.
clamps.
Just lift
Oh,
your
yeah,
leg.
yeah, sorry,
no,
sorry,
no,
sorry,
A
sorry.
regular one.
Just, yeah, just
Regular
like,
one.
yep.
Sorry,
And
sorry.
just make sure there's no hip flexion, right?
Yeah, you want it extended.
All right, next, glute, how about this one? Glute max, are you ready for this one? Glute max, non-weight bearing core and hip extension.
Oh, I got a good one. I got a good one.
An extension.
I don't want to say it though.
But with the core.
Oh, wait.
Oh, we can do that.
So plank, yeah, plank.
Yeah, I got you.
Extend your leg up.
Yeah.
Good. Excellent. So she's doing hip extension, she's getting core, and that's non-weight bearing. Excellent. Now, non-weight bearing core and hip abduction.
The side plank.
Like,
Oh,
Like this, up, down.
And now we're doing, instead of isometrically, now we're doing, let's see again.
Go up.
One.
and-
So we're doing the leg on top. You see that?
Yes.
Is
Yep.
that working your core?
Yes,
Is that working hip abduction?
yes.
Mhm.
Excellent. Now we're up to phase 2. Now we're doing glute med and
Couple.
max closed chain
Oh,
with TheraBand.
Keep getting confused what we're doing.
That's That's why I've been
Thank you.
announcing it.
Who's doing it? You're doing it?
Well, let's show with the TheraBand.
George just gonna do it on himself.
You take your time.
Don't we have like pre-tied ones?
No.
Usually classes
Yes, we
figure
do.
out to make a whole bunch of different.
Okay,
TheraBands.
so it's gonna be close change on one leg. So you keep this fixed and you move the.
It works.
It looks great, except looks like you're holding your underwear up. You know, the pants up. I mean, like
And you can
tie it properly. Tie
And
it
you
properly.
can change with how
Okay.
strong
Yeah,
this
you
is
can
by
go
moving
lower
it distally or proximally.
Yeah, so
All
that's
right,
easy.
very good. Now, finally, single leg closed chain, glute medius and maximus.
And the
Single
single leg deadlift.
Single leg deadlift works. I would use a weight.
Start. Hold on to something.
Yeah.
Put it like this.
Single leg deadlifts, and what else did you show?
Pistol squat.
Pistol squat also is good.
Oh,
Medium
God.
max. Okay. Finally, now we're going to talk about plyometrics. We're not going to show it because
Oh.
you guys know this, but you can show it. So we'll start with
Wait a
first
minute.
bilateral straight plane. So give me an easy bilateral straight plane.
That's
So now so we do not start doing this until we get the doctor's permission. But typically it goes non-weight bearing, then we go to elliptical because elliptical has no pounding at all. Then from elliptical, we might do light treadmill walking, and from light treadmill walking, then we start doing plyometrics with doctor's approval. Do you understand that progression?
Yes.
I would definitely know that progression. Okay, so now that we're up to the plyometrics, we start with bilateral straight plane. What's one you're going to show us? An easy
Ankle jumps.
Ankle jumps.
ankle jump. And if you show an ankle jump, it does not come. It's very little knee flexion. It's almost from the ankles. Good.
Yes.
Then a medium would be what?
Split squat.
A split squat jump.
Split squat, where you the leg in the front stays in the front, the leg behind stays in the back.
Yes.
And a more difficult one.
A cycled one.
Cycle is the high. Very good. When the patient then progresses to what? Multi-directional bilateral is what?
Jump over.
Jump over barrier.
Lateral barrier drop. Lateral,
We
or
can do
what's
the
another one?
zigzags.
Or zigzag,
Yeah, that would-
which you can get from the thing.
You guys are all over the
Zigzag.
place for me.
So it's zigzag or lateral barrier.
You're good, you're good.
And
I'm just filming
finally, you go to single leg hopping, which is any of the things we showed before, just with single leg and not double leg. Okay? How many, when we start, how many contacts do we make? That means every time the patient hits the floor, that's a contact. How many do we make?
300 to 400.
300 to 400. Why that magic number?
Quarter of a mile.
300 to 400 is a quarter mile. You build up
That's pretty
to that.
wild. I didn't know
When the
that.
patient is pain-free from 300 to 400, they are now ready to start running a quarter of the mile outside because 300 to 400 hits is a quarter mile. They run a quarter mile, okay? And then, how do you progress them? You go from a quarter mile to 16 miles in a week, correct?
Nah, you go from
No.
a quarter to a half.
10%.
10%.
How much is, when,
Every
in meters
week.
you mean? Oh, it's 200 meters. 400 meters? 400
What?
meters.
Then you
400 meters.
can increase 10% every week.
Only 10% a week. And the patient will laugh at you and say, no way. You say, well, then I'll see you again when you stretch your out. And obviously also, they should be seeing a dietitian. They should be seeing, obviously, multiple doctors. They even should be seeing a sports psychologist. Do you know of one? I wish I did. But because there's reasons why this is all happening. It could be psychological, it could be physiological, it could be metabolic, right? You have to explain all this to them. You don't tell them what to eat, that's not our job. You say it's a multi-tier approach. All right, I think we got everything, right? Good work, team.
Our modality is laser.
Oh, laser, yes. Tell us about, so you're gonna set the laser, thank you. You're gonna set the laser to reduce pain
Continue.
because of a bone issue,
Yeah.
right? Laser does not help bone mend, but it can control pain. And what would you set it to?
15 joules, whether it's acute or chronic.
Yes, that's an easy one, no?
Oh yeah, up to
Yeah.
15.
15 joules
Continuous.
continuous. And you'll
Nice.
put it on the side of fracture or around the side of fracture. That is totally okay. All right, that's it. That's all we got.
Nice.
Remember that your extra hip stuff is due Monday night.
Still running.
Please send it to your